Hello, everyone. My name is E. David Crawford, and we are continuing our three-part series about BPH, the market, options for treatment, patient management. In this part of the series, we will be discussing BPH care pathways and treatment options. And joining me today are two colleagues and good friends, Steve Kaplan and Kevin McVeary. Steve and I had an interview, I think it was last October, when the paper first came out about this Optilume, and was absolutely amazed at the data that was being presented. Steve is currently director of the Men's Wellness Program and at Mount Sinai Health, and professor of urology at the Icahn School of Medicine, Icahn rather, at Mount Sinai. So Steve, we're glad that you can join us, and also joining us is Dr. Kevin McVeary. Dr. McVeary joined the faculty at Loyola a few years ago. It just seemed like a couple of years ago. It's already been 6 years. He's been a professor at Northwestern and was at SIU before that. Both Steve and Kevin are outstanding researchers in the area of BPH and many other things. And I'm excited that they're joining us to go into part two of this trilogy that we're doing with this Optilume BPH catheter. And so at this point, I would like to turn it over to Dr. McVeary, who is going to begin the discussion. Kevin, great seeing you, my friend.
Absolutely. And thank you so much for the warm introduction, Dave. Always good to see you, Steve. It's always fun to work with you, and I look forward to learning from today's program. So I'm going to start the program really with this slide, which speaks to the idea of the BPH surgical market. And the message is that the market is vastly underserved. There's a huge pool of men with LUTS BPH. As you can see from the slide here, some 38 million. This breaks down to a really large portion which are not managed, or which are unmanaged. If we focus on the minority of men that are managed, they break into those men under like an active surveillance, where some physician is watching over them, but has decided not to treat. And then smaller minority, where men are on pharmaceutical therapy. And we'll get to that in a little bit. And in those men being treated with pharmaceuticals, there is a clear risk that they are going to fall out. They're going to fall out because of no symptom relief. They're going to fall out because of a side effect of the medication. And then some men just philosophically don't want to take medications. The idea is at least 10% of the men in this pool are going to need some type of intervention, non-medical intervention, in the next 4 years. So big pool. And if we look at the men who are actually undergoing surgical therapy every year, we're looking at really a small fraction. So it's a underserved population. It's a population at great need, and it's a population that's going to grow because of baby boomers. These baby boomers are headed into these pathways. Well, if we just take a step back and just look very superficially at diagnosis and treatment for BPH, this is derived from the AUA treatment guidelines. Critical to this pathway is the idea of actually taking a history, talking to patients. The guidelines still suggest an exam, a urinalysis, and some estimate is the patient have adequate renal function, because remember, we are urologists. And then this idea of PSA is really beyond the scope of this talk, but you want to keep PSA in your formula as you think about treatment. Part of taking the history is a symptom assessment. the AUA Symptom Index, or the International Prostate Symptom Score, kind of the state of the art internationally. 30 years we've been doing that. I want to encourage all the listeners to continue doing that. Once symptom scores are done, normally break men into those with mild symptoms, and there, watchful waiting is very appropriate for those men. Those men with more moderate or severe symptoms, those are the ones we want to focus on. Now, the algorithm would suggest, well, moderate, severe men go right to some kind of non-surgical management. Not necessarily, but just for the purposes of this talk, we can say that is a very common pathway. We'll get to what that common pathway, medication, in a second. Now, remember, if they're in retention, you treat them different. If they have recurrent urinary tract infections related to BPH, you treat them different. Hematuria, you got to evaluate. If they're developing bladder stones and have previously been treated, that's a failure. And remember, we are urologists. Our goal is preserve renal function. And if they have renal insufficiency related to BPH, these are reasons not to do a more conservative treatment like medicines, but instead to start to look at surgery itself. Well, what are the medical therapies? We talked about the algorithm. As we all know, alpha blockers are most commonly used as an initial therapy. PD5 inhibitors can be useful as for these men, particularly those that have concomitant ED. And so most men actually do get started on these alpha blockers, which are listed over here. And of course, we have lots of them, a partial listing anyway. When we look at men whose prostates might be bigger, then think about whether or not there's going to be a role for a 5-ARI. You want to hold that for men whose prostate is at least 30 grams. If it's smaller than that, you really don't get much bang for your buck if you're considering 5-alpha reductase inhibitors. I talked about the PD5 inhibitors a second ago. Again, something that you can have in your armamentarium. If symptoms are more overactivity, think about beta-3 agonists. And then in urology, we tend to use combination therapy, and this can lead to a problem. We'll talk about that in a second. The key and a new statement in the AUA guidelines is to reevaluate after you start medical therapy to see, is it doing the adequate job? Because if not, you want to start thinking about other options, such as surgical options, which we'll kind of segue to right now. One of the problems when you start combining all these medical therapies is this polypharma with multiple drugs with interactions which may be negative. We're concerned about some neurocognitive problems, and particularly in anticholinergics, and now perhaps even with long-term alpha blocker use. And we all know that there is a significant impact in sexual function, not just with the alpha blockers, with the 5-ARIs as well. So patients know this. They know it philosophically, and they know it in real time. And so they, in many cases, are reluctant to accept prolonged medical management and want to hear about other options. And that's where you come in. There are urologic outcomes which are also worth remembering from urologists, and that is the delay in the perhaps eventual definitive therapy for their bladder outlet. There can be development of detrusor instability, detrusor underactivity, and in a sense, you've complicated the surgical approach by the delay to it. And once these things happen to our bladders, when we get a bladder dysfunction, surgical intervention may not be successful. So reasons to always think about those men perhaps not responding. So we're going to segue now into the actual options themselves. Steve, I was wondering if you could talk to the group about the surgical management of LUTS.
So yes, thank you, Kevin, and thank you, Dave, for the kind introduction. It's been great kind of reliving some of the studies that we actually did. So with Kevin's great introduction, I think the issues that we're always going to be concerned about, regardless of which therapy we pick, is the symptom, if you will, severity at the time of. And most of these patients have significant symptoms, which is why they're open to the options of either a minimally invasive or surgical option. But what determines what we do, and prostate gland size and shape are just very, very important, because for minimally invasive therapies, most of the studies have been in prostates less than 80 grams. Some of them now have evolved in more than 80 grams. But essentially, the bigger the gland, we think more of surgical options, whatever you're comfortable with, whether it's traditional transurethral electrical approaches, laser approaches, and now with aquablation, another option as well. Now, what makes, if you will, us pick one therapy versus another, and certainly the presence of a median lobe and the significance of a median lobe, and we'll talk a little bit about later about using the Optilume for that, because many of the studies, the registration studies, specifically pick prostates that didn't have a large median lobe. And from a patient perspective, at the end of the day, they're the customer, and they're the patient who's they're the ones who are going to tell us whether things are working good. We can argue back and forth about data, but at the end of the day, it's how they feel, and sexual function is a big deal. And it's interesting for those therapies that really have significant effects on sexual function, particularly ejaculation, their kind of credo is, well, it doesn't really matter. And I think we would argue that it actually does for a lot of patients. So looking at that gives you the gamut of various therapies. And Kevin talked about the medical therapies. There's a host of these options, minimally invasive and surgical, but also there are some coming down the pipe. So this is kind of the treatment landscape. And what's nice, and many of you know most of these that are out there, a lot of these are obviously FDA approved. The Optilume BPH balloon, which we'll talk about, is the first and only that's kind of a combo. It's both a medication as well as a minimally invasive therapy. And I think that may lead to why we've seen some of the results that we've seen. And there's no head-to-head of these various types of therapies. But at least if you can look at and their various registration trials, we can look at a reasonable idea about how these play out. So this is the before and after for those of you who've actually performed it, or those of you who are interested in performing it. And I was involved with this before the clinical studies actually started. And we were trying to understand why doing an anterior commissurotomy, where really we split open the top of the prostate, really makes a difference. And it's real. It's a real phenomenon. And you can see it as you're doing the procedure. So I think the way I look at it is the traditional and historic balloon dilation was kind of taking an opening and making it larger. And here we're actually splitting the top, and we look at that kind of the A before and the inverted U after the commissurotomy. I will tell you, having done many of these, it's real. I mean, there's no question that this is real. And I think that's why we're seeing some of the real terrific flow rate results. And it's durable. And one could argue that the paclitaxel, which coats the balloon, has sustainability of these types of effects and perhaps decreases inflammation and scarring. So just in terms of the data, and we've discussed this in some of our previous pieces, we've had reproducibility, because one could argue, well, maybe that was a quirk in the trial. But actually, we've seen this now in the two pivotal studies, the Everest study, which was the phase 2, the Pinnacle study, which was the pivotal trial. And in fact, in the Pinnacle trial, for the first time, we saw that US, if you will, US data was even better than ex-US data, because the Everest was done in the Dominican Republic and in Panama. And usually those have the best results. In fact, Pinnacle was even better. And it's really because we learned during the process how to even do it better. And the results in flow rate are historic. I mean, we've never seen this with a minimally invasive device. They're more surgical-like, more than 10 mils per second. It's easy to do. It's not something that the first one, you're one and done. And I would say 5 to 10 cases, I think is reasonable. And most of them, on this past Tuesday, we did a case that was under LMA, under local with some sedation. Some people have done it under general. I think it's very similar to the other, whatever you're doing anesthetic for the current minimally invasive, UroLifts or Rezūms or iTind certainly would be applicable here as well. So in terms of sexual function, I'm going to turn this back to Kevin, because he's leading the investigation of the sexual function changes with the Optilume trial and is doing a publication on that. And I think is the best person to speak to some of the data.
Yeah, so thanks, Steve. So I do have a special interest in this aspect of all the myths. And like Steve had mentioned earlier, men who have LUTS BPH undergoing therapy, they're worried about their sexual function, and they may not voice it. And when you ask about it, that gives them permission to tell you how important it is to them. The good news is in the Optilume BPH study, there is remarkably no impact on sexual function. You can see on the left-hand side, the IIF score, the erectile function component of the IIF, it is essentially a straight line across. So this is really good news. When we take a look at the ejaculatory function, again, you see nearly a straight line all the way across. This is excellent news.
Yeah, it's almost like it's flat line there, Steve. I've never seen anything like this. It's totally unbelievable.
So when I got a first crack at the data looking at this, I was really shocked. It's you know, when you think about the change in flow, the change in symptom, you're thinking, well, there's definitely going to be some collateral damage, but you're really not seeing it, at least when we look objectively at symptom scores. What is, I think, most interesting is it's still important to talk to men because even just like this Optilume study and many of the other myths, when you ask patients their past sexual experience, have they even had one previous ED event, and you follow the men who've had a history of even one event, they do track differently, separately than the men who say, no, doc, I've been great my whole life. So if you're contemplating a missed therapy for a man, it would be in your best interest to ask the patient, have you ever had a sexual dysfunction in the past? What was the circumstances? Because that might put him at some risk. He's going to track different than the guys who say, no, I've been fantastic the entire time.
Very good. That's amazing. Let's just go to your conclusions here. Maybe the next slide. Have both of you comment as we take this thing on home and end here in a couple of minutes.
So I'll just make a comment about the clinical data because I was the PI of the study, and I hate making comparisons, but we can only extrapolate from registration data from each of the trials. And the IPSS improvement is similar to what we've seen with the other minimally invasive devices, but the flow rate, as you alluded to, Dave, is just really off the charts, and it's real. I was just telling you about a patient I did on Tuesday, and his flow rate just even 2 days later when we took the catheter out was remarkable. Even the PVR changes are more than we've seen. So there's not just subject; it's a real objective phenomenon, and it's real and it's reproducible in now 2 studies, and I suspect we're going to find this in clinical data as well. And the surgical retreatment rate was very, very low. Obviously, this is registration data. So there's always those caveats, and it seemed to be almost the lowest we've seen with previous data. But real world data is going to determine this, and that's really the play. And with respect to reimbursement, I think right now there is a reimbursement to the hospital. So they're pretty happy, and we'll see what office and physician. I think it's going to be off the top simply because it's a dual therapy. And the 0-day global. And at the end of the day, you know, there's the science and there's the economic science, and those are real phenomenon. And as Kevin alluded to, the improvement in sexual function, and he's one of the country's leaders in understanding changes in sexual function with BPH was minimal. So overall, we're enthusiastic about it, but at the end of the day, it's going to be what real world data is going to be, and hopefully you'll have the same type of experiences in your own hands.
I would endorse every comment that Steve has made. The clinical data is very strong. Your hospital, your business people are going to be happy about the reimbursement. And, you know, the 0-day global is really a benefit to practitioners and really in the best of patient care. So I'm really glad to see that was able to be put into the package. So I think it's going to be an interesting market in the next couple of years.
Thank you. Well, as I said earlier, the 3 of us have been involved with BPH studies our whole career, and I must say, this is probably the most impressive one that I've ever seen, and I think you guys reflect that too. And what we need are see what happens in the long term.